Hello, my name is Donna Cryer, and I am the founder and CEO of the Global Liver Institute. We are the conveners for International Nash Day, and I am over the moon excited to present this panel. Who has never been assembled. I feel this is like the Avengers or some other grouping of international or universal superheroes to talk about NASH as a global public health issue. NASH is a very serious disease affecting more than 115 million people around the globe. We know NASH has become more prevalent as obesity, type 2 diabetes, and other concurrent conditions increase. The pandemic intensified NASH with sedentary living, loss of income, and difficulty accessing healthy foods, exaggerating existing health inequities. More than ever, NASH requires expert attention, education, and action before it moves extend further. This International NASH Day, our theme is NASH around the world. We'll be bringing to you the experience of NASH from several countries, including the United States. And we are convening doctors, medical societies, patient advocacy organizations, civil society organizations, and academic institutions to bring you the top expertise and insights to share with your peers and patients around the world. I want to give a specific thank you to AASLD, the American Association for the Study of Liver Diseases, and for FAASLD, the European Association for the Study of the Liver, who endorsed this event. Additionally, we are so pleased to also have the endorsement of APASL, FOLDA, the ECPC, and other medical societies that you see here. The number increases every day as we scale to meet the needs of everyone around the world at risk of or living with NASH. We're also very pleased to announce our collaboration with the WHO this year and to have them on this panel. So without further ado, I will introduce my esteemed panel. Discussing NASH as a global public health challenge, which since the beginning of the Global Liver Institute's work in fatty liver disease and NASH, we have fought so hard to position it appropriately as a global public health challenge, knowing that we will need a public health approach to address and defeat it. So with me today, I have Dr. Zobair Younossi, professor and chairman of the Department of Medicine at Inova Fairfax Hospital, and one of the leading researchers and epidemiologists in NASH. I have Diana Alcantara-Payawal, past president and steering committee member for the Asian Pacific Association for the Study of the Liver, who comes to us from the Manila, Philippines. Dr. Raymond Chung, president of AASLD, the American Association for the Study of Liver Disease, professor of medicine at Harvard. I have Dr. Philip Newsom, who is Secretary General for AASLD, the European Association for the Study of the Liver, who comes to us from Birmingham, United Kingdom. And I have Kremlin Wickramasinghe, who is WHO European Office for the Prevention and Control of Non-Communicable Diseases leader. And we are so honored, truly honored to have you all speaking to the patients and clinicians and public health officials who are part of our audience today. And so with no more further ado, my panel. I'll start with you, Dr. Younossi, because you have done more, I think, than anyone else to really set the stage to inform us of the prevalence of NASH. And so let me start by having you give the context for this conversation.
Yeah, thanks, Donna, and thanks for asking me to participate in this wonderful event, which has been going on for a number of years. And it's really very important to have Global Liver Institute congratulated and sort of establishing this, because it really addresses an important issue in the context of non-alcoholic steatohepatitis or NASH. As you know, about 25% of the global population have NAFLD, which is the more encompassing term or disease. And that's really, as Donna suggested, is driven by the really pandemic of obesity and type 2 diabetes that is really plaguing every part of the world. The prevalence is going up, and actually is going up even in children. At least 10% of children have obesity. And again, the rates, the most recent data that we have looked at from global burden of disease suggests that the rates are actually going up in our kids. Of course, the major issue is that that NAFLD is not unique to the Western world. In fact, probably the highest prevalence of NAFLD is in Middle East and some part of Asia. And when you look at GBD data, global burden of disease data that we just looked at, in fact, when you look at 4 common liver diseases, hepatitis B, C, alcoholic liver disease, and non-alcoholic fatty liver disease, the fastest growing contribution to the burden of disease, that means mortality, that means incidence, that means DALYs, which is disability life years, are actually driven the most rapid pace by non-alcoholic fatty liver disease. Now, of course, the issue is that non-alcoholic fatty liver disease, and specifically the subtype of NASH, can lead to outcomes. These are really, I look at them at 3 different types of outcome. Clinical outcome, which is basically somewhat liver-related, such as cirrhosis and liver cancer, but it's also associated with non-hepatic cancers, or with sarcopenia, or with other what we call extrahepatic manifestations of non-alcoholic fatty liver disease. In fact, cardiovascular mortality is number 1 cause of death among these patients. The second type of outcome that's important is that it impacts patients' experience as assessed by patient-reported outcomes or quality of life. And finally, it impacts economic outcome. It has tremendous economic burden globally. There's been a number of studies that's been done. Now, the conundrum is that awareness about this disease is quite low in all aspects of the population. At the caregiver level, when you're outside hepatology and GI and primary care and endocrinology, where you see a lot of these patients, the awareness is quite low. And also the policy sort of makers level, the awareness is quite low. So this is why GLI is important with its mission to actually raise awareness. Of course, the other part of this conundrum is that there's really no approved treatment for this disease. Although there are a number of drugs that are available to manage obesity and diabetes, which could help, specific drugs for NASH has not been approved as of yet. And finally, currently NASH requires a liver biopsy, which is not a test that people will actually would be attracted to, obviously, because of the risk and the complications. So non-invasive tests are being developed. There are a number of good ones that are going to come down the pike. There is a European association that's actually looking at this called Litmus. There's a U.S. population collaboration. It's called NIMBLE. It's also addressing this, hopefully, and then of course industry is also developing something IT. So our goal is, number 1, to raise awareness. Number 2, to focus to find those patients who are at highest risk of bad outcomes, and then really develop non-invasive tests to identify these individuals, and then hopefully do lifestyle management in terms of obesity and type 2 diabetes to manage that. And finally, for some of these patients, we probably will need drugs that could address the steatohepatitis and the fibrosis part of this disease, as well as their quality of life of these patients that are really impacted on a long-term basis.
Zobair, I think that you so well set the stage for our entire conversation. I think that's fantastic. So, Dr. Newsom, we've been working very closely together on looking at the agenda on a global level for what it would take to address NASH. And there's been some, we can't ignore, however, that COVID has delayed that plan a little bit. What have been the barriers that the past 12 months of the pandemic have put up to our progress and momentum in NASH? But also, are there opportunities that have come out of this?
Yeah, no, hi Donna. So I think what COVID, over the last 15 months has told us is actually quite a lot around public health in many countries, and I think that really is relevant. We know that patients with NAFLD have obviously got overweight, often type 2 diabetes, and we know that these patients have had very poor outcomes over the last year and a half. So the one thing that we can take from COVID is that it has, in some respects, focused attention on improving public health, improving the general health of the nation. And NAFLD, in some respects, is a lens through which we can now view the population. So there may be an opportunity there, and I think there is, even in countries where there's been a reluctance to do this, we're now seeing moves towards targeting the causes of NAFLD. So measures to try and restrict advertising of junk food, high fat, high sugar products. And I think that's to me, I think that's probably the most important way that we can target preventing NAFLD. And Zobair has very nicely illustrated the innovations around diagnostics and therapies. And the great news clearly is that we've got a huge amount of investment going into both of those spaces. So for patients that do develop significant liver problems, I think there's a lot to do. I think one thing I've been sent to hear from the panel, which I think is still a major issue, is stigma. Mm-hmm. I think stigma is a real issue, both with healthcare professionals, but also with the general public. I think we need to think about the language that we use, and also we need to challenge people's views, because I think we're all very familiar with the kind of the language that's often used to describe our patients, our staff that have NAFLD. So I think that's a huge amount that we still need to achieve, and that's where I think you and the patient groups are going to be critically important in driving that.
Speaking of driving, as some of I drive a hepatic burgundy car with liver lady license plates, so that's part of my response to stigma. Do not embrace it. But Diana, we've been talking about, and Dr. Younossi mentioned specifically the high prevalence of NAFLD and NASH in the Middle East and throughout Asia. Can you talk to us about the experience of NASH and how it's the same, how it's different in the regions that you're working with?
Thank you very much for this invitation. Well, NAFLD prevalence in Asia ranges from 15% to 40%, while non-alcoholic steatohepatitis may range from 2 to 3%. And this is due to the rapid urbanization, modernization, and adoption of a lifestyle with reduced physical activity and increasing intake of calories that have resulted in the rising rates of obesity in the Asia-Pacific region. Like in India and China, we have shown an increase in the consumption of energy-dense food in the past decade, both in the urban and the rural communities. Non-obese NAFLD is more prevalent among the Asian countries, being about 38% of the Asian population. In Asia, actually, and that has been seen, have lower body mass index, but actually has higher total central adiposity for a given weight when compared with other populations. So this, I think, is something that we have to take into consideration, which makes us more susceptible to metabolic diseases. So metabolic obesity is mostly common among Asians. Now, the prevalence of childhood obesity, which was discussed earlier, is increasing also in India, Singapore, even in the Philippines, and in China and Malaysia. And the combination of this physical inactivity, hypertension, dyslipidemia, the large waist circumference, all add up to the problems related to that. I think this was before COVID, but during COVID, it becomes double. For a fact that in Asia, we do lockdowns. And with lockdowns, there is lower exercise, self-reported boredom, anxiety, depression, enhanced eating, and sometimes it's difficult to buy the good food, so you are snacking on chips. This consumption of snacks, unhealthy food, and sweets were all correlated to high weight gain. And now that some countries opened up and some of the patients are going back to the clinic, it becomes a problem for us. So I think the rate of NAFLD will actually increase because of COVID. Furthermore, it's not only that, it's the hazardous alcohol intake which becomes a problem also in our region. And because the drinking behavior during lockdown was common, in my country, I used to see when I was buying before the lockdown, I was buying food, but I saw some people buying a lot of alcohol. So before the lockdown, because there was a alcohol ban in my country. And this then adds up more problems that are, I think, going to be seen in the next few years. Now, the consequences of that is not only because most of our budgets are on communicable diseases, but now, as it was a pity because just before COVID, we were putting up already policies for non-communicable diseases. But with COVID, I think the budget for communicable diseases are going to hike or are going to be increased compared to non-communicable diseases. And this further puts a burden on the disease in my country. So I'll think also in the Asia Pacific region, because now you know that India is on lockdown, the Philippines is on lockdown, Japan is going on lockdown. So I think in Asia, most of the lockdowns actually will push people into more NAFLD and more problems as far as exercise is concerned.
You know, I participated in, I listened to a fantastic webinar last week done by some of my classmates, the Harvard Asian Alumni Association, on India specifically, but really as they're located throughout Asia or some of the United States with connections there. All of us trying to see how we can help. It was quite stark and quite eye-opening, and we hope to do more. All of this seems to be a setup for you, Kremlin, and the WHO, and how we can work with you to do better. But I'm going to, if I can, allow Dr. Chung, so we round out our hepatologist team here before we get to WHO. So, Dr. Chung, would you like to weigh in on what AASLD has been doing in Nash? I'm excited to have been a part of that through the task force with Dr. Younossi. But just your views, particularly in the past 12 months, of sort of how we knew Nash then and what we know we need to bring to Nash now.
Thank you, Donna. And again, AASLD is delighted to throw its support behind International Nash Day. It's become, I think, an even more important cause than ever. And I want to amplify on some of the comments that have already been made by Zobair, Phil, and Diana by saying that this is truly, particularly during the pandemic, become a global problem. And one of the things I think that is most noteworthy about NAFLD is that it is not a disorder of the liver, but it is a systemic disease that also happens to affect the liver. And so I think one of the most important things that we as an association have begun to realize as a liver society is that we cannot go it alone. And so we have deliberately, through the actions of our own NASH task force, reached out to partners to make this a much more holistic effort. And by partners, I mean, of course, not just patients through, for instance, the Global Liver Institute and other patient advocacy groups dedicated to fatty liver, but as well our professional associates, including our pathologists, our colleagues in endocrinology, the American Association for Clinical Endocrinology as an example, our colleagues in the Obesity Society, and our colleagues in the Cardiovascular Disease Society. Because of course, as has already been alluded to, this is not just about liver complications and mortality, but certainly about cardiovascular and potentially other forms of mortality, including even cancer. So with I think an acknowledgement that if we're going to manage and identify this condition, we're going to need to do this in partnership with certainly primary care providers on the ground, but as well with our colleagues who are seeing diabetic patients, in whom NASH is a particularly not just prevalent problem, but also a more severe problem. Our colleagues who take care of patients with obesity, our colleagues who take care of patients with cardiovascular disease. So out of this, I think we'll emerge, I think, much more comprehensive, much more harmonious, and much more far-reaching sets of guidances and recommendations for the identification and management of these patients. And I think it's the beginning of really our understanding that yes, as specialists, we have a great deal to offer in terms of really dictating the specific measures that relate to the liver, but also in providing, again, much more holistic care for our patients in partnership with our colleagues managing the entire body, if you will.
Ray, I think that is so important. We need everybody to claim NASH, to claim the fatty liver disease and NASH patient. And certainly all of the specialties and societies that you named and claimed. When we launched the GLI NASH Council 3 years ago, my first call was to the American Heart Association CEO. And so grateful that she answered. And now it's 70 members of the NASH Council, with everyone from the American College of Sports Medicine to the Association of Black Cardiologists. It is vital, as you said so well, that we pitch a very broad tent and invite everyone in to help us address NASH and really have a whole patient approach, a multi-systems approach, recognizing, of course, the centrality of the liver, I think. So, Kremlin, I want to ask you, having heard this, sort of super team from hepatology talk to you about the urgency and the seriousness of NASH as a public health issue. How do you hear this with your WHO ears? Does it make sense to you? Is it an aha moment? Is there we need to do more? Does it easily connect with things that the WHO is already doing? How do we work together on this International NASH Day and for the year to come and the years to come in truly elevating NASH as a public health challenge?
Thank you. Thank you for inviting us to be part of the panel. It's great to hear from all the experts that you have on the panel about the problem and what they're already doing. So our region, WHO European region, is about 53 countries. We have all the EU countries, former Soviet Union countries, and some Central Asian countries. So as you can imagine, the determinants, the obesity level and disease pattern are quite wide, broad, so it is an issue that we need to look at. Our office particularly focuses on non-communicable diseases, but I agree that we traditionally look at the 4 or 5 diseases: cardiovascular diseases, cancer, diabetes, chronic obstructive pulmonary disease, and now mental health. And then I am, as the acting program manager for nutrition, physical activity, and obesity, we link obesity to those diseases. It's rarely we link obesity and NASH when we try to raise the health issues related to obesity, or when we try to talk about the disease burden of non-communicable diseases. But looking at the trends and the disease burden that you are talking about, I think it makes sense that we take every opportunity to reflect on these diseases in our society and the disease burden to tackle, and also how tackling obesity can help all of those diseases. Our European program of work, New Policy Framework, talks about how to take people-centered approach, how to link the prevention and cure as a streamline rather than taking this compartmentalized or silo approach. So I think in all sense, it is important for us to link them. I heard a lot about obesity prevention as one key area to focus, and especially from Professor Newsom about the marketing restrictions and everything. That's a key area where we work from WHO. We like to take it as a life course approach. How can we work across the life course to tackle obesity and also to treat obesity? Obesity is a disease. It's recognized in ICD as a disease. And I also heard about the stigma you have for Nash. It's same for obesity. That's why we talk about people living with obesity and not to put the blame on people, but it's driven by a set of circumstances and determinants. And when it comes to life course approach, we start from breastfeeding, early complementary foods, which are 6 months to 36 months. A lot of these foods have more than 40% of energy coming from sugar, completely unregulated in many countries, and promoted as healthy or 1 of 5 a day of fruits and vegetables to mothers. And then childhood obesity. WHO has appointed a commission, independent commission on how to tackle childhood obesity. We have 6 key areas to focus on. Unfortunately, we can't map many countries who have implemented all 6 areas. Each country is trying to champion 1 or 2 policies, and we know 1 or 2 policies will not solve obesity. And then all the marketing restriction, digital marketing, and all the issues that we heard about. Finally, I want to make a comment about COVID and obesity. I think, yes, I hear that we know people living with obesity have a higher risk of getting hospital admission, ICU admission, ventilation, or death from COVID. So looking at the data, we would assume this is a good opportunity to convince the policymakers to tackle obesity or even include obesity prevention strategies in their COVID response. Yes, that's from evidence perspective. But unfortunately, what's happening is the same situation is used by industry to reverse some of our policies, to go and lobby government saying this is economically difficult, their profits are going down, they're losing jobs, so they want to reverse some of these marketing restrictions, some of the reformulation restrictions government have in place. So I think it's important all the clinical societies, public health experts, everyone keep this issue high on the agenda and keep our pressure to keep the obesity prevention policies intact and further strengthen them, which will be helpful to tackle NASH and many other diseases which are part of obesity. Thank you.
Thank you. And I want to follow that with Zobair to you and the economic impact. So if industry is talking about their economic analysis, we have our own economic analysis about the impact of fatty liver disease and NASH on patients, on families, on communities, on employers and productivity. So tell us a little bit more about the economic impact of this condition. I was going to go to Zobair, and then Kremlin, fine, happy to have you follow back up.
Well, the economic impact of Novelty in NASH is really very hard to assess, but it could be, it's really enormous. And the reason is that there's some direct sort of economic impact of the liver disease. It's related to cirrhosis, liver cancer, liver transplantation, and that there are a number of indirect impact that we need to also assess to the patient. Now, you have to take that into in the context of the family and others is going to be really, really huge. So we've done a few of these models, Markov models, to sort of estimate what will be the economic impact of Novelty in the United States and EU. When you're looking at just direct impact, you're talking about hundreds of millions of dollars and billions. But what is actually important is that NAFLD is associated with fatigue. It's not an asymptomatic disease. People think it's asymptomatic. It is actually not an asymptomatic disease. It's associated with significant fatigue that is actually going to have impact on work productivity. So if you look at work productivity studies that we've done to assess the other type of impact of non-alcoholic fatty liver disease that can become also enormous. And as both Phil and Ray suggested, that this is a systemic disease. So to just pull out just the liver impact of Novelty is probably just looking at just the tip of the iceberg. Then we have to bring in the cardiovascular impact. I suspect that certain patients with NASH will have more aggressive cardiac disease or maybe some other type of cancer. So the total economic impact, when you're looking at direct impact of the disease, the indirect impact of patient quality of life and work productivity specifically related to fatigue, and then of course other intangibles that are also gonna be as a part of the total global burden of this disease from economic standpoint would be enormous.
So I think that seems like an area for additional research and to partner with employers so that we can really understand the impact of NASH in those economic terms more fully as we flesh out the argument, as well as continue the work that I know you've been leading in patient-reported outcomes, so that even these subtle effects are better captured, so that they can be better communicated to folks.
Yeah, I think that's a really important issue, Donna. And unfortunately, it depends on the health system that you're dealing with, the region of the world or the country. So in certain countries, including ours in the United States, there is a lot more emphasis on the policy side has been on communicable diseases, but also on diseases that has had a direct sort of very clear clinical impact, like cancer or cardiovascular disease. This disease, I think we need to raise awareness. And of course, in terms of the payers, if the payers are not homogeneous, if you have very disjointed payers, as you have in the United States, then it's going to be sort of a moving and pushing sort of the ball from the private payers to the governmental payers like Medicare in the future. What has to happen here is that there is nothing that we can actually do in terms of managing the economic burden of this unless we make a national policy about this disease. And this has to be done on a country basis, on a regional basis, and on a global basis. This is why having WHO is so important, because it will be really WHO's non-communicable disease sort of aspect of WHO that needs to promote this as a very important complication of obesity and type 2 diabetes and really move that forward, because you can actually just address a small bit of this issue in one country or another, but you're not going to really address the whole disease and the whole economic burden unless it's at the policy level.
Exactly. It's so to have all of you assembled, and the GLI has worked on our U.S. NASH action plan, which we do hope will be adopted as the roadmap in the United States, and worked with Dr. Lazarus and the AASLD Foundation and Wilton Park Group, aligning that work so that we are in concert together on what is a global approach. Dr. Newsom, when we think about moving forward, because we've addressed many challenges here, and started to outline some opportunities in food policy and others, but what are some of the other opportunities that we have in NASH globally, whether they're in non-invasive diagnostics or in drug development? What are the opportunities on the horizon?
Well, there's a huge amount, as we've sort of touched on. I mean, I think that for non-invasive diagnostics, I think there's going to be a range of hopefully new developments that allow us to, inform patients, just how significant the fatty liver disease is, and I think more importantly also, how it changes over time. So if, for example, somebody receives a treatment, being able to say whether or not there's been an improvement or not without having to go to liver biopsy, which is far from perfect, I think will be really helpful. Now, there's been so much going on in that area that I'm very confident we'll have that. In terms of treatments, again, it's really exciting. I think there's umpteen different phase 2 and phase 3 trials going on. So it's an amazing time. And I'm sure we'll end up with various approaches, combinations, depending on the stage of disease for individuals. I think one thing that perhaps we might think about in terms of interventions is how we trial lifestyle interventions. So I'm not talking here. Kremlin mentioned, changes in public health, clearly very important. Obviously politically challenging at times, but how do we evidence, if you like, the best lifestyle intervention? And that's one that I think is going to be quite important, because I think, given the scale of the problem here, I think it always, you can see a layering of public health, lifestyle changes. What's the best lifestyle change, and critically, what's a sustainable lifestyle change? I mean, we know how difficult it is to adopt these changes, but to keep them adopted is really quite difficult, and then above that we'll have drugs. But if I could maybe ask a question of Zobair, actually. So Zobair, I'd love your data on the patient-reported outcomes, and symptoms in NAFLD. And one of the things I wonder is, to what extent are those symptoms likely to change when you have changes in NASH that are, say, not linked to changes in weight or changes in glycemic control? Because there was some interesting data a few years ago, but I just wondered what your thoughts were on that.
No, certainly. When you look at any disease, any liver disease or any other disease, chronic disease, comorbidities can be driver of impairment of PROs and quality of life. That's certainly true. But there are actually some liver-specific sort of aspect of the impairment of quality of life. For example, there is no doubt that having more advanced stages of fibrosis actually drives PROs, and all liver diseases, including NASH. Additionally, in NASH, we have shown, and others have shown from UK, that when you have more active disease, for example, more steatohepatitis, that you have more impairment of quality of life. I suspect that has to do with sort of the systemic inflammatory milieu of obesity, driven by obesity, that can impact patients and in their mental health and as well as their physical health. So it is going to be a sort of comorbidity driven, and in this context would be primarily driven by type 2 diabetes, maybe some with obesity, but then there's going to be some liver specific aspect of quality of life impairment that's going to be important, and that needs to be assessed. And this is really why I think PROs are sort of this type of outcome that had not been historically emphasized by hepatologists. It's really very important, and other diseases like cancer and other areas, we need to really make sure that we address it, because from a patient perspective, if you say that the patient has gone from stage 1 to stage 2, it really means nothing to the patient. It's patient experience that's more important. So if patients can actually stay in stage 2 for all their lives, but they actually have terrible quality of life, that's what actually is important to them to improve that. So whatever drugs that we have cannot add to the impairment of quality of life. That's the side effect profile issue. On the other hand, these drugs, as if they improve the comorbidities, for example, some of the GLP-1s can reduce the weight, address diabetes, it should actually improve quality of life. And as they improve steatohepatitis and actually fibrosis, I suspect that they should improve quality of life and PROs. And that's really important sort of comprehensive assessment of outcome. That's not just clinical outcome, but also PROs and economic outcome.
I really appreciate you saying that, Zobair. As a long-term GI and hepatology patient, I've sat in many a doctor's office redoing the questionnaires to make them relevant to how I was experiencing care, and now for GLI to be working collaboratively with many research groups to have that patient input into the design of patient-reported outcomes and the validation of them, and supporting the use, I think is really important. I remember talking with several NASH patients, assessing the side effects profile of some different drugs in the pipeline, and at a very simple patient level, we all agreed we'd rather be itchy than dead. So, there are things that we can put up with to save our lives. And whether we die from, cardiovascular event or a liver event, we're still dead, and we'd rather not be. And so I think patients are very practical, and the communication and then the translation into a quantitative narrative for regulators and others about how patients weigh risks and benefits is something that we'll be moving forward in our patient-focused drug development meeting in Nash later this year. But we really appreciate a researcher of your standing carrying that banner of how important this aspect is. So I thank you. And I want to extend the thanks to Dr. Chung, who has integrated patients and patient insights at such a rapid pace over the past year in your COVID programs, in the Nash task force. And, I wanted to ask, as we think about partnering together as medical societies and patient advocacy organizations on Nash and other types of liver disease, how has that changed, your thinking about things, your leadership and your work?
I don't think there's any question, Donna, that taking those first steps as we did a couple of years ago into the patient space, if you will, has been an extraordinarily gratifying step for all of us. I mean, it's actually reminded us daily and visibly of our purpose. We're a mission-driven organization to prevent, cure liver disease, and to not have had patients as part of our organization's activities was really a void, quite honestly. And I think once we integrated the patient and patient voice, their point of view, their input into our programming, into our activities, into our committees, into our guidance and guidelines, there's suddenly this feeling of being whole again, right? And so this has been an extraordinarily gratifying, really move for all of us. And I hope and I believe that the patients view it that way as well.
We do.
And I think a very important aspect of this is for instance, their participation on our guidance and guidelines committees has really, made us think continually about what are we trying to message to our patients. I mean, it's not just directing our messages to providers, but it's to the patient community. So much so that we've now established an initiative to not just offer the published or web-based guidance or guideline, which I think is wonderful in its own right, but as well to produce a companion patient guide to the guidance, if you will, put in plain language for them to comprehend and really take home. So I think patients and integrating them into our life has made it real for us, and I think it's just a continual reminder of our purpose.
It is really my greatest joy in all the work that I do to mentor and train patients who want to make that transformation into patient advocacy and to learn the different skills and terminology through our Advanced Advocacy Academy so that they can be really successful and productive when partnering on different AASLD committees. It's not something that's sort of tissue, when you're in the hospital or, and so to be able to, bring patients along and equip them to really be productive, constructive members of these new types of collaborations, just really is my heart. And I really, all the patients who participated in efforts with AASLD have had, just such a great experience reported back. So I thank you. As our time grows close, I wanted to ask Diana about, the scalability of different aspects of NAFLD and Nash management to different countries and different environments. It's one thing to have, a big imaging machine in Fairfax, Virginia. Does that same machine or technology work in the Philippines? I always ask my team for some that we're putting forward? Does it work in Seattle and Senegal? And so, about identifying NASH patients, what will make it scalable and what will make sure that we can have care that reaches everyone?
Well, for a fact, in the Asian countries, most of the countries are actually self-generate medical costs. In other words, they pay their own.
Mm-hmm.
So this has an impact as far as monitoring and surveillance of patients. 38% of lean NAFLD exist in Asia. And I think that's a growing concern because they are left not diagnosed,
Mm-hmm.
not monitored. And probably this has an impact as far as recognizing these patients early on. So when I was looking at the different countries in Asia as far as policies are concerned, they do have some policies, but whether they are implemented properly and whether they are actually triggered down the lines of the frontliners and all of the other specialties becomes a burden to us. So I think surveillance and implementation of the policies are a problem. Most of us are burdened with communicable diseases.
Mm-hmm.
So I think Asian countries are still there, and the non-communicable diseases are still being shelved up. So I think this is a problem that we have to face. Like in APASL, we still are working on viral hepatitis, and there's a group working on NAFLD right now, and we are actually working on we came up with our guidelines on this. But as I mentioned, whether this is actually being followed and whether this is actually being done because of the COVID pandemic, people are giving all the budgets of the government are geared towards that. It's quite different in Asia. So I think we still have to lobby some more as far as advocacies is concerned. I'm very happy that being part of the International NASH Day will be a foot forward for us to look into these programs in our area.
Maybe I can just make one comment, Donna, about Asian countries and NASH. The two issues that's absolutely critical. One, you heard from Diana that we incorrectly look at BMI as categorization of different disease risk factor for fatty liver. It's really waist circumference. It's visceral obesity that drives this disease. And it's not total body fat. It's actually primarily, maybe they correlate with each other, obviously. So in Eastern countries, in Asian countries, it's primarily the visceral obesity, because if you look at visceral obesity, then everything actually will be the same in terms of risk factors. The second issue is that NITs that actually are validated in the Western world should not be assumed that it will work in the Asian countries. So what is actually NITs, they need to be revalidated in Asian countries to make sure that we have the proper NITs. And second, and this is going back to what Phil suggests in terms of drugs, unless we do international studies, because this is really an international disease, it's a global disease, or at least have these drugs reassessed in terms of efficacy and effectiveness in each part of the world, then we are not really addressing the global, pandemic that I call for obesity and NAFLD. So I think it is absolutely critical. The industry understands this. NITs need to be revalidated, and drugs have to be actually validated in every country in terms of efficacy and effectiveness.
I absolutely agree. And, we have worked to help define or redefine what, diversity means when you're doing a global trial in NASH. How many patients do you need to be in each country or of each, ethnicity, or what does genetic diversity look like when you're doing trials for a drug that you want to be able to work across the world? And so I think that is a hugely important question, as well as the non-invasive diagnostics validation. So I'm going to have this sort of last word that we want people to end with, and maybe I will go in order of Dr. Newsom, Dr. Chung. Dr. Payawal, Kremlin, and let Zobair, you have the last word. So, Dr. Newsom, what do you want people to have as the main takeaway? So between now and next International NASH Day, what would you most want people to do?
Well, I think the key thing is working, with you and the patient groups to raise awareness, to really fight stigma, and to really push, I think, for clear guidelines in the management of these patients. At the moment, it's fairly variable across countries. So I think they're the three priorities from my perspective, or from EASL's perspective.
Thank you. Dr. Chung?
Donna, yeah, from AASLD's perspective, I think publicity about this disease, and as Phil alluded to, I think that we're going to move the needle only when we can issue clear-headed guidance to people who matter in terms of financing healthcare. And so if we're going to change the view toward screening approaches to fatty liver disease and management approaches to fatty liver disease, we need to get our guidance out there. And it's our intention to be out front with that guidance to make that as crystal clear based on all the evidence as we can to help drive subsequent action on the part of people who can help deliver this, namely payers.
Dr. Alcantara-Payawal?
In our region, I think it's the inadequate awareness which still exists among common people and even the specialists. Mm-hmm. And I think a large proportion of even the general practitioners and physicians in many disciplines are not even familiar with official guidelines. So I think education for the general population and targeted training programs for physicians are clearly indicated or urgently required in Asia. One of the drawbacks, I think, is for the advocacies. We've shown it in our viral hepatitis advocacy programs with patient groups that they really were able to conquer viral hepatitis in some countries. And I think advocacy groups like this group that you have will play a major role in our area.
Thank you. Kremlin.
Thank you. So I would touch on 2 points. One is we heard about the importance of changing lifestyles to tackle the disease. And we know for changing lifestyles, one of the most cost-effective intervention is primary healthcare workers talking about it with patients, not when they are patients, at any opportunity they get in the primary healthcare system. And I know at the moment, most of these lifestyles, related to diet or physical activity, they talk to patients in the context of tackling diabetes or heart disease or cancer. So putting NASH into that basket of things that they initiate a dialogue is going to be important. So you have more work to do with primary healthcare professionals to bring it into the discussion. Secondly, I heard about the need for national level actions policies. Learning from all the other non-communicable diseases, what we need for that is national level data and national level multi-sectoral stakeholders. Building the international case with international research is important, but we know that alone has not been enough to really accelerate action at national level. The local policymakers want to see data coming from their country and local stakeholders advocating for that policy. That's what we have learned from other NCDs, and that's what we are trying to do. I think it's applicable here as well. Thank you for inviting us.
Absolutely. We look forward to partnering with you on that in every zip code, town, country, state, and nation. Zobair.
Well, there is no doubt that this is one of the most important diseases, non-communicable diseases that we need to really focus on. There is plenty of evidence suggests that it is very, very common and it's growing, that it touches all types of outcomes, clinical outcome, patient-reported outcome, economic outcome. The biggest challenge we have, I think we have a number of challenges in this field that we have to prioritize. Of course, we've got drugs and ITs, all of those in how do you optimize lifestyle management, and how do you work with other societies? But awareness is absolutely the most important one. When we actually achieve that level of awareness, that when patients hear about NASH, they have the same sort of reaction that as any other chronic disease. Mm-hmm. When you actually see a diabetologist or a primary care physician that see a patient with diabetes and say, I'm going to send you to ophthalmologist to check your eye exam, I'm going to check a creatinine to check your kidney function, but I'm going to also check your liver because this is an important liver disease. Mm-hmm. I think that level of awareness is going to be really critical. And that's where sort of a multi-pronged approach at all these levels would be important, because we can develop the best drug and the best NITs. But if people are not aware or don't actually consider the disease to be that important, nobody's going to use it. And we have learned that from other diseases. So I think it's really important that we push everything from our societies with Ray and Phil and Diana and others, and from our patient sort of advocacy and policy institutes like yourself, and also from both national and global leadership of WHO, that we need to really take that this holistic approach, that we need to address all of these aspects. It'll take time. This is not going to be something that we can address with 12 weeks of treatment. This is going to be something that is going to be lifelong for patients, and we're going to have to also gear up for that kind of a challenge.
I can end on no better note. So well said. Thank you all for your participation in this first of its kind, first of its level panel with representation from all of your organizations, so that we can speak with one voice about the seriousness of NASH as a global public health challenge. I thank you. And to everyone who wants to replay this panel for all the many things that we've heard, or watch the other panels for International NASH Day on issues that we've alluded to, whether it's children with NASH or NASH in lean individuals or NASH and obesity. You can find all the information on our globalliver.org website, on our Facebook, Twitter, Instagram. You can follow the hashtag NASH Day. And we thank you for this time and throughout International NASH Day and for the next year to come.
Thank you.
Thank you.